the cloud, yeah.
Okay. All right. Thank you. I thought so, but anyway, so for those of you who don't know who we are, we're NAMI Howard County. We are the local Howard County affiliate of the National Alliance on Mental Illness. We provide free programming, education classes, support groups, and outreach programs for individuals and families affected by mental illness. Um, I'm at the end of I have a couple announcements, but just related to our education programming, we do have a class called the Basics class that's going to be starting, and that is for parents and caregivers of school-age kids up to 22 who may be having behavioral health concerns. So that class is starting in October, but I can talk a little bit more about that when we're done. But just real quick, I wanted to introduce the NAMI Howard County staff. Susanna, Heather, and Kristen, if you could just give a little beauty queen wave would be great. And also to shout out our board members out there, Topaz Navarro, Suzanne Cavaness, Jessica Kaufman, and I think we were expecting one other one. I'm not sure if she made it in yet, but Nairi Price is one of our board members too. So before I get started, I just wanted to mention a couple ground rules. Please keep yourselves muted during the presentation. If you forget, we should be able to mute you, but please be respectful and keep yourself muted. Secondly, any questions that you have that come up during the presentation, if you could put them in the chat. I'm going to try to wait until the very end to ask Dr. Greenberger all the questions that we have. But if there's like a clarification on something he just was talking about or a slide, I will try to interrupt him and ask him. But I'm hoping to keep all the questions till the end. And so then we will be monitoring that, the chat. So yeah, so I'm going to get started then. I'm going to share a little bit about who we have this evening. Welcome, Dr. Greenberger. We're very thrilled to have you tonight. He is a dually board certified psychiatrist in child and adolescent psychiatry and adult psychiatry. He's the owner and medical director of Collaborative Counseling Center and Collaborative Counseling TMS here in Columbia. He specializes in the treatment of children, adolescents, young adults, and adults. He provides psychiatric services, including psychiatric evaluations, ADHD evaluations, medication management, gene site testing, and TMS, which, as we'll get into, stands for Transcranial Magnetic Stimulation Therapy for teens and adults. He believes in treating the whole client, which includes their family, school, and community. So, Dr. Greenberger, you can take it away.
Thank you so much for that nice introduction. I have been working in the community for many years, almost 25 years now, and it's a pleasure to be here speaking before everybody. There we go. Oh, so this is more about me. I think you just shared all of this. I'm going to kind of skip that slide. We don't need that. So thank you, NAMI, just for having me out. I really do appreciate it. This opportunity, you know, the incredible work that you guys do, not just in our community in Howard County, but also throughout the state and throughout the country. I was sharing with somebody, a patient in my office just the other day, and they had been involved with NAMI kind of on the team teaching classes years ago, and just kind of excited to hear that I was given this talk tonight. What we're going to cover tonight is a few different things. We're going to start. I'm going to kind of just review, you know, what major depressive disorder is, and that's really what most people are kind of thinking about when they say someone's struggling with depression. There are other types of depression. There's different umbrellas under which we think about depression, but the primary one, the most common one, the one that is what are referred to when you're kind of seeing statistics and numbers and kind of things in newspapers and the news, and really what we'll be speaking about tonight is major depressive disorder. We'll also talk about the common treatments for major depressive disorder. We're going to talk about TMS, what it is, how it can be helpful in the treatment of major depression. And we'll talk about how it works as an innovative kind of non-medication treatment for depression and also for OCD as well. And this is in adults. So the 9 symptoms of depression, of major depression, they're the same for adults and teens. We don't have a different diagnostic criteria when we're thinking about this for teens and for adults, although there can certainly be some differences in how teenagers experience some of these symptoms. And I've got another slide I'm going to get to in a moment where I'll kind of just highlight some of those differences. But the core criteria, the core diagnosis, is based upon a depressed mood, loss of interest or pleasure in things, changes in appetite, either increase or decrease, sleep disturbances, insomnia or oversleeping, psychomotor agitation, or so either kind of an activation and elevated psychomotor activity or a reduction in that as well would count. Fatigue, loss of energy, feelings of worthlessness or guilt, kind of excessive anxiety about oneself, impaired concentration or indecisiveness, trouble staying focused on things and being productive. And the last, kind of suicidal thoughts or kind of recurrent thoughts about death in general, even separate from suicidality, can be also thoughts about kind of death. And so these are the core symptoms. There's different degrees of severity. There's, major depressive disorder. There's mild, moderate, severe. There is severe with psychotic symptoms, where there's sometimes folks with depression will experience some paranoia or some hallucinations occasionally at that severe level. There's the single episode, and there's recurrent episodes. There's a lot of specifiers. That is based on both the severity of these symptoms, the duration of them, kind of how impaired somebody is as a result. One thing I like to share with folks about depression that I think really is probably underappreciated or not realized by many. The criteria require the symptoms and to be at a certain severity for 2 weeks. This is not something that a person has to be struggling with for months or years of time. 2 weeks of severe symptoms would be a major depressive episode. And so, how to help folks when they're struggling with this, how to get help, sooner rather than later, reaching out to folks within the community, whether reaching out to NAMI, getting a referral, seeing a therapist, connecting with a psychiatrist. If there's safety concerns, obviously we have emergency rooms all over that are always available for urgent visits if things are severe quickly. So I was going to share a little bit, some of the things that are a little different sometimes in teenagers. The kind of irritable mood or frustration. Sometimes teenagers are a little less able to identify, or there's kind of a difference in how they experience not so much sadness, but more of an irritability that can be instead. The other thing that I think we see differently in teenagers, the loss of interest or pleasure in usual activities is something we see across ages. I think sometimes teenagers, more so than adults, I think adults will often withdraw from social interactions and social situations earlier in the course of a depression, where teenagers often will still be able to spend time with friends, experience time with friends, and even get little breaks sometimes from the depression. So, a teenager's ability to enjoy some time with a friend does not mean that they're not struggling with depression. And so I think that's just another piece to kind of keep in mind. Low self-esteem, feeling worse about themselves, or kind of over-focusing on past struggles, the trouble thinking, concentrating, making decisions. I think a lot of teenagers struggle with some of these things anyway, but kind of how that can be impacted by depression. kind of the common out, like how common this is. This kind of youth risk behavior survey that was performed from 2013 to 2023. Just sharing some trends. In 2023, the CDC kind of their data revealing that about 40% of students had persistent feelings of sadness or hopelessness, and about 20% had thought about suicide, and 9%, almost 1 in 10, had done something to try to end their lives. This is much more common than people realize, and the duration does not have to be so long. There is help out there. There's lots of things that we can do to help. The feelings of distress were found to be more common in female students, more common in LGBTQ students, and some differences across racial and ethnic groups. Asian and white students in this survey were found to be less likely to attempt suicide than students of other races and ethnicities. Um, and so there's a lot of work to be done to help folks, and there's more options now than we've ever had available to be helpful for folks, teens or adults struggling with depression. Some of the more common treatments, I just kind of list them here. There's various types of counseling and therapy, cognitive behavioral therapy, commonly referred to as CBT. I had somebody recently who I was recommending. They're like, what is that? And so just kind of spelling it out, cognitive behavioral therapy is the most studied therapy, the one that has a lot of data for its effectiveness for the treatment of anxiety and depression, but multiple other therapies as well, really needing to personalize things based on the individual, the family, some of the subtleties of the struggle. But interpersonal therapy, there's mindfulness-based cognitive therapy. Dialectical behavioral therapy is something that also is regularly spoken about and regularly talked about for teens. I'll just make a point briefly that dialectical behavioral therapy is actually a subtype of CBT. It is a type of CBT. There's also another, I didn't put this in here, but exposure and response prevention is a therapy specifically really for OCD. Typically is how it's thought of, is also another subtype of CBT. We've also got behavioral activation and supportive therapy. And so these are all really important options, and important to get some support and counseling therapy to kind of change how we're thinking about things, how somebody who's depressed is processing, and giving them some support to try to rethink some of the ways they're approaching their struggles and challenges. We use medications, obviously, medication management. And I just list a few of the classes of medicines. The SSRIs, the most common. That is selective serotonin reuptake inhibitors. That is the group that contains Prozac, Zoloft, Paxil, Lexapro, Celexa, Luvox. That's kind of the group of meds that really emerged in the 80s and has shown itself to be highly effective for both depression and anxiety. We have the SNRIs, the serotonin norepinephrine reuptake inhibitors, another class of meds. And in this group, probably one of the older ones in the group is Effexor. We also have Cymbalta, Pristiq, Fatsima. There are atypical antidepressants, antidepressants that work in slightly different fashions, including so there's a new group of SSRIs. We also have Wellbutrin, mirtazapine. The tricyclic antidepressants are the older group of antidepressants. Those are the ones from really the 70s and even in the 60s. This is a group of meds that has other precautions and monitoring, a different set of side effects. But sometimes these can be helpful for folks as well if some of the newer meds haven't been effective. The monoamine oxidase inhibitors, this is really a very old group of meds. It comes with a lot of restrictions and precautions. Most folks will never take one of those. I've only prescribed an MAOI maybe a handful of times in my career. And then we move beyond the medicine and the therapy when, trying different courses of therapy, trying different courses of medication have failed to achieve, adequate results. And maybe I'll kind of interject here kind of two things that we look for in the treatment of depression. We're looking for clear response. We're looking for responses where folks are clearly doing better and any symptoms are well moderated, but really that's inadequate. That's not enough when we're treating somebody and helping somebody with depression. The real goal for the treatment of depression in particular is remission. And it's different than when we're treating anxiety or OCD. I'll often tell folks, anxiety, a certain level of anxiety is actually healthy and can be constructive and positive, protective, cautious. We don't want it to be too much. We don't want it to be interfering, but anxiety doesn't go to a zero. It doesn't go away. It's actually not healthy to have zero anxiety. For depression, we want it gone. The goal is to have it gone to help folks to achieve remission. And so when we're coming up short and we're not able to do that through the counseling and medication, interventional psychiatry is the area that we now have as an option. And so TMS is what we're going to talk about. TMS is FDA approved for adults with major depression, as is ketamine treatment, as is ECT. And generally, if I've got somebody, I would recommend them in that order. Due to general safety, side effect profile, likelihood of response. The ECT is the most effective of the interventions for depression, but it comes with, a much greater load of potential side effects. And if somebody needs it, it can be really helpful. And I've had many patients where that ends up being the case. But we have TMS and ketamine for adults, which can be tried before moving on to ECT. For teens, we have TMS, which is also FDA approved in teenagers 15 and up. And ECT is also approved for the treatment of depression in teens. What I've got here, kind of APA treatment guidelines, this is just kind of showing some of the general recommendations, kind of a consensus recommendation for kind of where different treatments fit into the algorithm. And you'll notice across the bottom of the slide, what I have here is psychotherapy is throughout. And so I kind of had that listed on a prior slide as the different counseling interventions. And that's something that we really do want to be doing for folks, along with whatever other treatment interventions we are looking at and talking about. Typically the first line treatments are the SSRIs or the SNRIs. If that's ineffective, many insurance companies are prepared to move forward with TMS and approving that. It is that effective. It is that safe as the second intervention. The FDA approved it as the second intervention for teenagers as well. Sometimes folks, not uncommonly, I would say most of the time, folks are trying more than one medicine before they're finding their way to me for TMS. And kind of changing of the antidepressant is often another strategy that is tried. Sometimes folks will use augmenting strategies. And then there's augmenting medications. The atypical antipsychotic group, we've got 3 meds approved there. Moving down the line, you see ECT there. And beyond ECT, we have VNS, which is vagal nerve stimulator. So those are treatments after other things have failed. I don't see ketamine on their algorithm, but I think that I would put it in after TMS before ECT is kind of where I would insert that into this algorithm. So about my practices, the practices we have here, family owned and operated. We're right in Columbia, across from the mall right now. And collaborative counseling, TMS, is where we offer TMS therapy to help patients with major depression. We've got a great team that is working to do that. Multiple certified treaters. We work directly with insurance companies. We accept all insurance as a part of the TMS work that we do. Opening that up to every insurance company. I get questions often, do we accept Medical assistance, yes. Medicare, yes. We work with veterans as well. We accept VA benefits. That was actually a long time in the process to obtain that. Actually, the VA benefits were the longest uh, entity to get approval through, and it's been really fulfilling to help veterans when they're struggling and they've tried other things and just need another treatment intervention, namely the TMS. With that practice, we have quick availability. Patients can be seen within 1 to 2 weeks from their first inquiry. I'll go through the process and what's involved with that a little bit later. I also have a second practice, and really it was before the TMS practice, so maybe it's the first practice, Collaborative Counseling Center. And this is where we offer psychiatric services. I've got a team of psychiatrists now as well. We do medication management, psychiatric evaluations. We do gene site testing. Through this practice, we have various therapies that we provide, individual counseling, group counseling, family counseling, parent support. We've got a multidisciplinary team here for that center, for the Collaborative Counseling Center. We're out of network for insurance. So they are two separate entities. And in that one, it is out of network. For the TMS practice, we work with all insurance companies. So what is TMS? What is this? So what it stands for, thank you, Denise. I think you pointed that out at the beginning. It does stand for Transcranial Magnetic Stimulation. It is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain to improve the symptoms of depression. It is typically used when the medicines haven't been effective, or sometimes as an alternative to medication. It is for the treatment of major depressive disorder. It is FDA approved for major depression in adults and for adolescents 15 years and older. It is also approved for the treatment of obsessive compulsive disorder and anxious depression, and has been highly effective in the folks that we've treated for those conditions as well. So treating depression at the source, these two PET scan images are actually multiple superimposed images from multiple individuals struggling with depression and multiple individuals that are not struggling with depression. And the depressed brain is not signaling, is not active in the way that a non-depressed brain would be. And depression is caused by this decreased activity. Whether it's caused or it's a feature of, it is certainly a clear characteristic of depression. And the TMS is going right at the source. It is trying to wake up parts of the brain that are not functioning properly. I've got some other images that'll show specific parts where the TMS is actually activating the brain to wake up. And it is, a non-drug treatment, and does not have systemic side effects throughout the body, trying to get the brain back into this non-depressed state rather than being in the depressed state. These images, when we move somebody from depressed to non-depressed, when we get them into remission, their brain functioning will mirror that of somebody who's not depressed. I like to point out that would be the case whether it was therapy that was the helpful intervention, whether it was medication that was the intervention, whether it was TMS, ketamine, whatever the treatment was. When somebody is no longer depressed, when they're in remission, their brain chemistry is functioning appropriately again. And so this could be somebody who is on a medicine, who's not on a medicine. Once the state of depression has been relieved and alleviated, brain chemistry functions appropriately again. And that's the goal. That's what we're trying to get folks to. So who's a candidate here? Who may be a good candidate? It is approved for adults with depression and OCD. It's approved as for teens. Actually, the FDA approved it as the second intervention for teenagers. The initial adult approval, when things are initially proposed, things are tried in folks where other interventions had been ineffective. So the early studies for adults were all after 4 failed medicines. And folks had to often, even with insurance companies, had to fail at least 4 meds before they could get approved from their insurance in order to try TMS. That data has since changed, and the line has moved. Many insurance companies now for adults require just 1. Some require 2. I think one of them is still asking for 4 meds. For teenagers, the FDA approved it as the second intervention. So even without a single medicine tried. So trying therapy hasn't been effective. The FDA has approved it as the second intervention for teenagers. It just based on its safety and efficacy. Often for the adult population, folks that have tried medicine and therapy and they haven't been able to achieve remission, folks continuing to experience depressive symptoms. If folks try medicine, but they're having lots of side effects from the medications, they don't have to stay on them, don't have to continue to experience side effects. We can kind of look to other things. TMS does not have kind of the body side effects that medications would often have. Sometimes for folks that wish to avoid antidepressants also. And so these are, folks that we would consider good candidates, and we would assess and talk to and see whether it might be appropriate for them. The unfortunate reality that this slide kind of demonstrates for us a little bit is that with each additional medicine tried, the likelihood of achieving remission actually goes down. The first medicine is the most likely to achieve remission. Nearly 28% of folks will be able to do that. There's a greater response than there is remission, and so responses are going to be a bit higher, but this slide is showing remission rates. And with each additional medicine, kind of the likelihood of achieving remission goes down. So this is where newer studies after the FDA approval for adults said, why do we have to go so far? Why is it necessary to be a part of that 93%? Do we have to prove to be part of that 93% before TMS would be appropriate? And that's where really most of the insurance companies have moved the line back to 2 meds. Rather than 4. And so NeuroStar is the company, the chair that I have here. It is, I think of it as kind of the Cadillac of TMS. It is a precise treatment. It is very focused. There's other devices, there's other chairs out there. The NeuroStar is very focused on the specific part of the brain that we want to treat, and has really good data for many folks, and is the only device that has the approval for teenagers. So the other chairs, the other devices have not done the studies, have not kind of shown the same data and the same results for teens. And so with collaborative counseling, TMS, we really try to keep it as simple and easy as possible for folks that are reaching out to us for this service. Really, you just got to kind of show up. We will do the rest. We will handle all the insurance process. You kind of come in, you sit down. A typical treatment, the most likely is that it is under 19 minutes a day, sitting in the chair, receiving the pulses. Folks can drive in to treatment. They can drive out of treatment. There's no restrictions. There's no precautions around the treatments like they have for some of the for ketamine or for ECT. For ECT, you can't kind of function. You really have to be in the hospital to even receive that. As in an initial course, sometimes they'll send folks home after they've begun a course. With ketamine, you can't drive a car. You can't work. With TMS, we have folks coming either before school, after school. We've got college students that come in the middle of their school day. Folks come during work, during lunch breaks, and kind of go right back to the workplace. A full course of treatment, is what is recommended, what's prescribed. And a full course for major depression is 36 treatment sessions. It is important to complete all the data. I'm going to show you some numbers in a moment, are based upon completing all 36 treatments. That's where we get the best results. Sometimes folks start to feel better earlier. We want to get in remission. And then after we achieve that, we want to stay there. So even folks that experience improvement sooner rather than later it is important to finish the full course. The goal is to get and stay in remission. So of completing a full course is what we do there. Now, I'm saying specifically 36 for major depression. If somebody were coming in for TMS or OCD, a full course for OCD is actually 29 treatments. And so that would require the 29. Typically, what we're doing here in the state of Maryland, insurance companies are not yet cooperating or approving for OCD alone treatment. So we are here at Collaborative Counseling, TMS. What we're doing is if we have somebody who's suffering from depression and also struggles with OCD, we are adding the OCD treatment along with their depression. So, and they just have to be here for a little longer because it's a second protocol that is added in addition to the depression protocol. And so by adding it along with the depression, we're not dealing with the insurance company at all, and we're just kind of throwing that in as an additional benefit of being here for treatment. So the process here, for somebody who's interested, reaching out to us, the first step, kind of calling. And we do free consultations. Folks can meet with our clinical coordinator, learn more about TMS, kind of discuss, parts of your history, of your situation, your symptoms. There'll be a rating scale that's typically involved. And if it is appropriate, they will schedule an evaluation with myself, Dr. Greenberger, where I'll do a full psychiatric evaluation and will consult with outside providers, with the patient's psychiatrist. I do this as a consultation for patients in the community with therapists and psychiatrists. You're not leaving your psychiatrist, you're not leaving your therapist, you stay under their care. And I do a consultation for TMS to see whether this might be appropriate. If we determine that is appropriate, a good treatment, we schedule the first day. The first visit is where we do a motor threshold, which involves several different pieces, several different parts of that process, identifying kind of the ideal location for the individual, finding that part of their brain, and finding the right energy level for that individual, for each individual. And then they also receive the first treatment on that first day. Then we schedule their treatments. We schedule the 36 treatments for folks. The majority are under 20 minutes. Occasionally, probably less than 5% of folks will have treatment sessions that are a little bit longer than 20 minutes. Again, it is individualized to the person. And so there are some situations where it needs to be a little bit longer, and we'll figure that out on the first day. We won't know that until after that motor threshold day. During treatment here at Collaborative Counseling, we also always have somebody in the room. There's always somebody highly trained with you throughout the course of treatment, talking with you, providing some support. Folks can be on their phone. Some folks listen to podcasts, or can listen to music, or have just a conversation with the treater that's in the room. Often folks are seeing improvement in the depression, certainly within the 3 to 4 weeks. We often see symptoms starting to improve even earlier than that. But kind of the depression itself, kind of the subjective sadness, we're often seeing improvement in that 3rd, 4th week of treatment. And it's 36 treatments is a 7-week course, a little bit longer than that even. We're doing 5 days a week of treatment. Folks also get a follow-up visit with me after the course of treatment where they can kind of share about their experience. We make sure that things are working, that things have been effective. I'll coordinate with outside providers again. If there's questions throughout, I will sometimes add a visit during the course of treatment. If there's questions that need more of a sit-down visit discussion with me rather than answering through one of the treaters or me popping into a treatment and providing answers kind of, right on the spot there. But everybody gets this. This is what everybody gets. And so the adult indications for use, I just kind of list them here separately. The adult indications are for major depressive disorder or for OCD. For adolescents, we have it FDA approved for major depression. The safety note here, does talk about a side effect of some discomfort at the site of the pulses on the first day of treatment. About 50% of folks have a little mild discomfort right at the site where the pulses are being delivered. By day 5, that drops down to 5%, and we can adjust the energy to kind of minimize that. It is transient. Everybody gets used to it, and we can adjust the energy to make sure that it's not too uncomfortable. I always love the 50% where there's no discomfort and they're just fine and kind of good to go. But it is extremely common for there to be a little bit of discomfort right on the first day. There is also this rare risk of seizure. Now, this is, what do we have here? Less than 0.01%. So the number there is 1 in 10,000. And it's actually a little bit less than that. Years ago, earlier in when TMS was earlier approved, there were some treatments that were done on the right side, either in addition to the left side or instead of the left side. The current treatments, the current protocols, there is no reason to move to the right side. The left-sided treatment is the one that's approved and the one that is effective. And on the right-sided treatments, there was a higher risk of seizures just by virtue of that portion of the brain is a little bit more sensitive. So it's actually even a little less than 1 in 10,000 people. Somebody who has epilepsy would be someone who's not a great candidate for TMS. If somebody has had multiple seizures, we don't want, their brain is a little more sensitive to that. And so, but for the majority of folks, where it is an effective treatment for depression, and that would be the group that we would not look to be doing TMS for. So the minimal side effects, I just kind of reviewed this, I think, on the other slide. I guess at the bottom here, they've got a note in particular for teens. Depression, antidepressant medications can sometimes cause, or worsen suicidal thoughts in adolescents. All of the antidepressants do carry a black box warning from the FDA about that possible risk of increased suicidality. A beautiful thing about TMS is it does not have that risk. It is not a risk with TMS. It has not been demonstrated as a risk. And so that's another thing that we can avoid. Of all the different pages, lists of medications that are out there and available for adults, there's actually only 2 antidepressants that are even FDA approved for adolescents. We have Prozac and Lexapro for older teens. Those are the only 2 that have FDA approval for adolescents with depression. Now, often we'll use other medicines because we need to try to find options that are helpful for folks. But the other FDA approved treatment intervention is TMS. So there's kind of 3 interventions that are approved, 3 in addition to therapy, 3 non-therapy interventions that are FDA approved. And so this is an image of the arm. The NeuroStar magnet is contained in the arm here. And what it does is it generates, focused magnetic fields, which generate a local current in the cortex to depolarize the brain cells, the neurons, eliciting signals, action potentials, causing the release of neurotransmitters, the release and reuptake of neurotransmitters. So here is kind of where the slide, where the magnet is placed. Over the left dorsolateral prefrontal cortex is kind of the region of the brain that we're targeting. And that is a more superficial part of the brain that is accessible to the pulses. And when this region is depolarized, it also sends signals deeper into the brain, where there's other limbic structures, other emotional centers. And so it's kind of a gateway to deeper emotional centers. And I've got another image here. I think it is coming up in a moment. The activation of those deeper brain regions is also supported in this final image. You can see the more superficial region here is from the direct stimulation of the magnetic pulses. And these deeper parts of the brain are secondarily being activated by that by activating that left dorsolateral prefrontal, the more superficial portion. And so we are activating, exciting, waking up these deeper parts of the brain, these emotional centers, in order to help lift folks out of depression. And so it's specifically targeting these regions. And this is where the NeuroStar is more focal and can be more localized. There are others that are trying to target the deeper centers directly rather than accessing it through a more superficial region. And so this is safer, I think better tolerated, and this is where we were able to get the approval for teens as well. And so the goal, as I shared before, is remission, seeing yourself depression-free. It is a safe and effective treatment option. It's FDA approved for teens and adults. It is non-invasive. There are not, side effects throughout the body. It is 36 treatments, is a full course of treatment. We do 5 sessions a week. Often at the end, we'll kind of do a mild taper to gently reduce, but we can also go straight through. There's new data that it is as effective without the taper and just completing 36 days in a row. Similarly, I always get a question, what if somebody has to miss something? I'll just kind of jump to that. I'm not sure if you'll get one of those in a moment, Denise, but I'll kind of jump to there. And one nice thing, I do feel, really, really proud actually that, we were able to remain open throughout COVID. Throughout COVID, we remained open and were able to continue providing this treatment for folks struggling with depression. If somebody is not well, if somebody is ill, if somebody came down with COVID, they would stay home, they would not come in. We've continued to disinfect every surface in the treatment room. Missing a number of days for an illness and returning and completing the 36 does not interfere with the effectiveness of the treatment. So completing all 36 treatments, we try not to miss if we don't have to, but if somebody is ill, they stay home, get better, come back when they're feeling well, and we continue the course. They're not missing the treatments. We put it on hold until they're well enough to return, and they still get all 36 treatments. Again, the 20 minutes, typically each is actually just under 19 minutes. Occasionally somebody's over. Proven results for adolescents. So the adolescent data, this was over 10,000 or nearly 10,000 since this data was published. It's even a little bit more than 10,000 have been treated, and 78% experienced significant improvement. So that is clear improvements, but not quite into remission. And 48% will be able to achieve remission with TMS. Highly effective. This definition of remission does not mean that somebody doesn't feel sad occasionally, once in a while, or even one bad day per week. What it means is that they're no longer meeting criteria for major depressive disorder. That's kind of where we started. So, folks can have some symptoms that are mild, that are not most days, that are occasional, rather than pervasive and persistent and chronic. And so having a symptom occasionally, it is not major depression. And so achieving remission is where we've really gotten rid of that depressive process. And so 48% is a very good number. For adults, it's even better by clinician ratings. When clinicians are talking with folks, the improvement, the clear response is 83%, and remission is at 62%. What I will also point out a little bit here, these results down at the bottom are separating out patient rating versus clinical rating. So that is kind of the provider's rating. And so the providers are often rating folks a little bit better than folks are perhaps rating themselves. we're still getting 36% into remission here, and another 70% are having a clear and significant response. It's probably somewhere in between these two numbers for remission, but I think the importance that folks may still have some times where they feel sad, but that they're no longer meeting criteria is what that 62% is identifying. And so just really good numbers. This is an incredibly effective. I showed you that slide with kind of each medicine, the likelihood of achieving remission. The likelihood of achieving remission with TMS is better than any single medicine can provide. Here we've got kind of PHQ-9. This is one of the mood rating scales that we sometimes use to assess depression. Often, I think lots of medical practices now, pediatric groups are using this scale. It's a regularly used depression rating scale. And the degree of improvement that we see across ages, this is just really to point out that we're seeing similar degrees of improvement, approximately 50% better and a 50% reduction overall in PHQ rating scales. Now, there's folks that aren't improving. There's that smaller group where they're not getting improvement. So that obviously affects the averages here. But this is across all ages, the 15 to 18, 19 to 21. This is when they kind of pool those together, 15 to 21, and then adults 22 and over. Clear, significant, approximately 50% improvement in PHQ-9s. I like this slide actually a little bit better. I think this image, kind of the pre-treatment PHQ-9 and the post-treatment PHQ-9, where more than 50% were in that severe range at the get-go before starting TMS, and we get the severe rating down to less than 10% by the end of treatment. Some of these folks will not even be considered responders, even though they're significantly better and no longer in that severe category, because they just haven't improved enough. But clearly, you can see that what we've done is we've moved from a predominance of severe depression and moderately severe depression to mild to minimal or only moderate. And so we're really shifting the severity of depression and moving so many folks into this mild to minimal. And this would be where there would be where we'd be talking about remission for a portion of this group here. With collaborative counseling, TMS, we take care of the paperwork. You kind of provide us the information. We take every insurance company. We've got some of them listed here. We work with any insurance company, and we'll try to make sure that we can get the treatment covered if we think that it is also appropriate for you. Why folks choose us, why folks come here to collaborative counseling TMS. One thing is that, we really work hard to provide a warm and comfortable environment. It is supportive from entry through exit. We really are kind of personalizing everything, and we use a patient-centered approach and individualize everything that we can. We always have a skilled treater in the room. There are places where you have a TV and a call button, and if you need something, you can kind of, reach out to have somebody come in with you. That is never something that I even considered. There is some data to support that providing support, a little bit of counseling. We're not doing therapy during the treatments, but providing that support does increase the likelihood of response and remission. And so we are here to provide whatever support we can throughout the course of treatment. I think our location is also convenient for lots of folks. So we are doing our best to get the word out and let folks know where we are. So they throw this in here for me, this slide in here. So as someone who is board certified in child and adolescent psychiatry, I treat a lot of adolescents. By virtue of that, I have had more adolescents treated here at Collaborative Counseling TMS than many other places throughout the country. Our approach, our practice, that dual board certification, I think there might be one other TMS provider in the state of Maryland right now who is also board certified in child and adolescent psychiatry, but there are not many of us throughout the country. This is a more recent approval for teens and adolescents. And so with the dual board certification for child and adolescent psychiatry, I think lots of folks have felt more comfortable having me kind of assess their teens for the appropriateness of this, rather than going to an adult doctor who doesn't have the additional training and expertise in treating adolescents and working with the whole family. So what do they have here? The #1 in the kind of mid-Atlantic, and one of the top providers in the country also. So common questions, these are, common questions that we always hear from folks. I'll try to kind of answer these also right now off the bat before we get to the Q&A portion. Does it hurt? And so, I did share earlier some discomfort at the site of your scalp, right where the pulses are being delivered, while they're being delivered. And during a treatment session, the under 19-minute treatment session, there are portions, there's kind of seconds where the treatment is being provided, then there's a pause, then there's treatment provided, and there's a pause. And so the discomfort is only during the pulse delivery, not in the pauses. And it drops to 5% by day 5. So really everybody gets used to it. We can adjust the energy to make sure that is tolerable and not too much for folks. The cost does depend on the insurance plan. We work with every insurance company. They're really all covering it. So kind of the varied cost ends up really being about like an individual's plan and their copay. Some insurance companies, some plans have zero copay, $10, $20, $30. It really ends up being kind of the daily copay is what folks, what the family, the individual responsibility ends up being. Again, because we will work with every insurance company. Sometimes if there's a deductible that needs to be met, that's another piece. But again, we work with every insurance company. The last question, I think I've said it many times, does it work? Yes, it works. There's lots of studies. We've got a lot of data to show how effective it is and how safe it is. For folks that are interested, kind of scheduling that free consultation, reaching out to our office. I've got the phone number here on the slide, or emailing Avneet directly, and we will do whatever we can to get folks that consultation, the discussion, and scheduled to see me if after that discussion and consultation it's something that is appropriate and seems like could be helpful for you. So we'll work with providers again, like folks are not scheduling with me to become their psychiatrist. This is not an intake. This is a TMS consultation, and I coordinate with other folks throughout the community. And this is for the purpose of TMS. So I think sometimes folks don't want to have to start over or start new, and that's not what this is. You remain under the care of your psychiatrist, your therapist, and you're seeing me for consideration of TMS, and I will supervise and manage that portion of the treatment while you remain under the care of your outpatient providers and your care team. So this is a slide we've got here. What you can see in these kind of blue, this is kind of a cutout in the shape of a brain, and in the room that I'm sitting in, I'm in our TMS room right now, actually. We have dozens of these hanging throughout the room. These are comments that others who've completed a course of treatment kind of share with us. So just kind of pulled a couple to share. And thank you all so much for restoring me. For a very long time, I felt like a broken toy. Now I see everything vividly. Every day I realize I'm happy in moments that before were silent yet loud. I thought I'd never see my way out, but TMS was the light at the end of the tunnel. I am a better mom, daughter, and every day I want to live. Thank you. And they put a date on that. The other one here, and I've got multiple kind of, comments with similar sentiment, but kind of individually worded, however the individual kind of shared that. The second one that I kind of pulled here, TMS has made it so much easier to complete my daily tasks and also to enjoy things that had lost their shine 6 weeks ago. I'm spending more time with friends. I'm spending time with friends more, skating more, reading more, living more. Thank you, CCTMS, for your support along this journey. And on the image, you could see they also drew some flowers along and a sun shining there. And so we've got multiple testimonials as well. This is just some a little bit of the team. Myself and Avneet is our clinical director. We've got kind of Megan, Ella, Marley, all kind of treaters helping in different capacities. Emily Greenberger has also been clinical director in the past, kind of helps in multiple capacities with different parts of TMS. And so here I've got just a little thank you, and I've got these two QR codes. And there's kind of information if you wanted to scan the, is TMS right for me? I'm going to leave this up while we're doing some questions. We've got the phone number, the email, and if folks did want to, scan that QR code, I think there'll be a rating scale there, entering some information, and if it seems like it would be appropriate, we can have somebody reach out to you directly after you kind of scan that code and answer a few questions. Why don't I stop there? I've been talking for a bit. I'm going to take a sip of my beverage as well. I hope that was helpful. I do talk about a lot of these things, most of these things, almost every day. And so sometimes I'll talk a little faster, a little slower, or I'll kind of leave something out that, hopefully that was thorough. I tried to follow my team's instructions and kind of, stick to the slides. But let me kind of stop there and see. I'm sure we've got some questions and things to answer.
Yeah, I just want to say thank you so much. That was a really comprehensive presentation. So I thought there was a lot of good information in there. We don't have too many questions in the chat, just
Sure.
one. But if people can also, after I'm done with the question we have here, we can also make it a little more casual if people want to unmute themselves.
Yeah,
But
absolutely.
Leslie, oh, I'm sorry. So the one question we did have was from Leslie. She asked if you perform accelerated TMS similar to the SAINT protocol developed at Stanford.
So that's a great question, and I have had folks call to inquire about that. The SAINT protocol is where all 36 treatments are performed in 5 days, and so we're not doing that right now. It is something that could be found perhaps in our region. Most folks are not doing it. The added piece to that, unfortunately, is that insurance companies won't cover it yet. And so it ends up kind of shifting the burden of the cost of treatment fully really onto the patient instead of onto the insurance company. It is nice to be able to do something so quickly. It's fairly intense, where I talked about folks coming in kind of before work, after work, in the middle of a lunch break. If you're doing 10 treatments a day for 5 days, or however, what is it, 7? It would be 7 treatments a day. One a day gets 8, to get 36 in a 5-day course. You're spending the whole day in the treatment center. You're not kind of in and out. And so that's not something that we're doing right now.
Okay, we had another question and a comment. Oh, yes, thank you. I'm going to stop recording.
If you want, or you can leave it on, whatever your preference is fine with me. Yeah.
Yeah, I think just maybe
Sure.
people will feel a little more comfortable
Sure.
asking questions if they're not being recorded. So,
Oh, okay.
yep.
Fair enough.